officers of the chapter, all the senior teachers, and my girlfriend sitting there. And all my students. Developmental pediatrics, we need to establish ourselves. We are talking big about development pediatrics, we are having conferences, etc., etc. But from the government side, it has not matched. So as a specialty, we need to establish. And I realized maybe a little late that most of this can happen not by only by your publication. Government documents, things have to come. So we had a long discussion and we thought of coming out with a national guideline on habilitation process for neurodevelopmental disorders and etc. And we wrote up the whole thing, sent to the Indian pediatrics, and a smart person, I believe it's a lady, gave so bad comments, unbelievable. As usual, first time you get angry little bit and upset. But then I always do like that. I thought about it and started reading each one of the comments. And I realized she had sense, or he or she, whoever it is, I don't know who it is, had sense. Because she is trying to divert the whole topic into a something which is not scientific alone, but it will attract the policy makers. So from that point of view, thanks her or him, whoever it is, we sat again and made it all over again. And now it has come out, and these are the people, all the training centers chiefs are involved in that. Okay, what is the objective as per the document? I won't read everything. Prevention and early diagnosis using validated Indian tools. That is the most important thing. If you have to use foreign tools, our pediatricians are not going to use it because basically you are supposed to pay for it. Management of NDDs using Indian therapy models. We need to publish more of Indian therapy models. We are still talking about teach and all that. Why can't we have something for India? And third one is define the role of development pediatrics as a specialist clinical consultant. And fourth will be define the role of development therapist for early stimulation therapy at community mobile units. Kerala has shown the model how they can be used in the community. They are multi-purpose, not just one. Next. Okay, so how did you process? I won't take much time on the process, but I have to say, we reviewed the literature, developed key questions, prepared the first draft on guidelines, and that's the one I said got critical review. And then we had guidelines were discussed again by the whole group through online meetings, and general consensus arrived and vetted. Final guidelines were drafted by a writing group, approved by each member, and we distributed to the same thing was approved by the executive of the chapter as well as the executive of the Indian Academy of Pediatrics. So it becomes a solid document. Now, this is only for publication. I don't think you will be interested in that. It's a modified Delphine method, same thing what I said. We won't spend time on that. Now, why we are doing it? Because there are 3 stages. First stage is pre-conception, then the neonatal, and then the developmental. All 3 has to come together, and I will talk about it. WHO had already said that we need to do the pre-conception counseling, and we are going to have a module, I think finalized now, on pre-conception counseling, Academy's module on pre-conception counseling. Surely we don't want unintended pregnancies. We don't want preterm low birth rate to go up. We don't want much birth defect. We definitely do not want IUD, intra-uterine infection, STIs. And the key word for development, 3 things which I teach MBBS students, 3 causes only: hypoxia, hypoglycemia, and septic shock. These are the 3 things that we focus. And then of course, risk of later metabolic syndrome for IUD babies, which is what I had done, followed up them for 25 years, waited 5 years for 3 foreign examiners, 5 years it took them and 32 queries. And I really admired them because they ask all sort of questions, but the language is so sweet, not unlike most of us. We actually get angry with the students. They are so polite, but the problem is that the first one, they will say what you have written answer is not agreeing to what you said for the third question, which means I have to start all over again. Anyway, that is ultimately led to the DSc, Doctor of Science. Now, WHO's policy is not only pregnancy, infancy, newborn infancy and toddlerhood, they are also extending to adolescence on one side, extending to up to 18 years on the other side, at least up to 12 years, because then only learning disability comes. I won't go much on that. And then, what are the 10 commandments for preconception counseling? Okay? You have family life education for adolescents, we have talked about it, we don't have to say anything more. Immunization, rubella almost become universal. Hepatitis B, at least 50% of children get it. But human papillomavirus, I think we need to push it. When it came, we didn't push it because of the cost, but now the cost is not a big issue because everything else is costly. So I think we should do that. Pre-conceptional folic acid. I think this is one I will spend half a minute. Neural tube develops like a neural plate. It becomes fold itself and become a neural tube. And if you don't give this one, there will be a gap through which the nerves come out. So it has been proved beyond all doubt that folic acid will make sure that at least 70%, 75% of neural tube defect can be. Then of course we need body image issues, dental care of course, and then medical checkup, particularly I think this is something very important. One ultrasound of abdomen. You don't have to expose the child, you don't have to examine. Just one, this is one place where I don't encourage too much of exposure and too much of touching the baby or child. You can have one ultrasound, it will tell you everything about inside. Normally we don't take that policy. Examine. But in adolescents, probably they will be much more comfortable if you go for an ultrasound, which will tell you your uterus is okay, ovary is okay, your kidney is okay, your liver is okay, everything is okay. Because why I started emphasizing, because I had a girl who actually after 3 months after marriage had congenital polycystic kidney and she had a lot of problems. And the whole family blamed that you cheated us. So let's not get into that. Then of course, reproductive health screening, mental health screening. I forgot one thing about examination of breasts. Gone are the days when we do mammogram or biopsy, all that. Now it is not there. If you ask, there is a person in Amrita who is doing only breast examination. Whole life she has, morning to evening she only do it, and she vows that surely that if you can do a good examination, you don't need to do all this, and she has contributed 2 chapters for my book on that. Sexual health, mental health, sexual health counseling, newlywed counseling, and some amount of self-counseling. Self-counseling is you can learn yourself to counsel. I have tried this for last so many years. I have been into all sort of problems, but I never sought counseling help because I myself can counsel myself. All of us can do that. Then habilitation, first 1,000 days. You start with a joyful pregnancy, no stress for the mother. That is the most important. Second, organized newborn resuscitation program. NNF is doing so beautifully, IAP is doing so beautifully. Then lactation management, antenatal, natal, postnatal. You don't need details of that. Risk stratification of NICU graduates either by NNF protocol or a new protocol we are developing. Newborn screening for hypothyroidism, G6PD, CAH, etc. Some places, each place out of the 4, you choose any 3, that each place is different. Government of India supported. Development and follow-up and early stimulation for NIC, not only NICU, SNCU graduates, whoever there. And last, of course, counseling parents on home environment. If any of you don't have, get this home screening questionnaire, which has been validated against HOME, home observation for measurement of environment, which will take home visit and another 2 hours. This will take only 5 to 10 minutes. So chest tube, something you can get from the net only. Okay. Then role of developmental therapists. We started, the first course we started in 1995 as PG diploma in clinical child development, and now whole Kerala, at least in Kerala, almost all hospitals, wherever there is neonatology, they have a newborn for development therapists. And then, what is their role? This we need to be clear. Number one is, they are an assistant, they are not the doctor. Get it very clear. Unlike all other therapy, where they say, we don't want doctor, we will do everything yourself. Okay? All of us have suffered because of that policy. I also had back pain. I went for therapy for a long time. Then when I got a CT scan, it was a lumbar compression fracture. Okay? So all of us make this mistake. Okay? Because they are not doctors, they don't make diagnosis. But they are excellent in their work. Don't deny that. They are very good in their work. All therapists are well trained for their work, although they are trained more for adults, and then they are come to children, but they can't come to newborn now. That may not be possible. The first 2 years is 90% medical. Get that clear. 90% medical. Without a medical person, others can do. So what we need is a person who is assisting you. That is the assistant. And then community services, documentation, research and publication. So all this they can be the thing. Next. Now we know what can we do with the gynecologist or obstetrician. It's actually a beautiful study, 94. This is the only study I've seen in the world literature where attributable risks have been assigned. Attributable risk means if you say 40, severe anemia 34.5 means 35% of low birth weight can be removed from the community if you avoid anemia. Similarly, each one, non-pregnant weight, high, maternal high. How do you do that? Pre-pubertal. That's why we are emphasizing on class 1 to 4. Before they get menses, you have to focus on the nutrition. After that, it will only make you thick. But before that, you put on weight. That's a very important concept. Okay? Then, of course, folic acid, I said, all these problems, way back in 1977, 79, and my MD thesis was this. At that time, we didn't know about anything about folic acid. We thought it was, a fungus that was the cause. But then now we know that is the folic acid is the cause. Okay. Then what is habilitation? Very simple. It is prevention of impairment leading on to disability. You don't talk about disability, but the whole literature has been mucked up because in US, unless you have the word disability, you won't get the government payment for intervention. Get the point? So, the whole of Europe, US is talking about disability. Every child is disability. There is no word about impairment, they don't talk about development. The reason being, if you write, ABD also disability. If ASD also disability, learning disability, everything disability if you write, even at a small hearing disability, it's not hearing impairment, hearing disability, vision, okay? Now we are talking so much about CVI, that is another important area I didn't mention, but that is very important. What we used to previously called as cortical visual impairment, now is cerebral visual impairment. So much of data is coming on that, okay? So that is important. So prevention, early stimulation, early detection, early intervention for development delay, then assessment of neurodevelopmental disorders, colic disorder, not disability, and then team of development therapists, development nurse counselor, development pediatrician working together. That is the most important. This is the only slide I want you to take. If you want to take photograph, take it. This is the whole crux of this talk. That is, every year we do surveys on disability and the same fellow who is limping will be picked up. And we keep on saying this is disability. What is the purpose? What do we do for them? Some small things we will do as a social commitment. But we can't do anything much beyond that. Disability cannot disappear. Okay, once disability, there is disability. But the impact can be reduced. Whereas what is happening is below the water. There are a whole lot of development delay, communication delay, language delay, motor delay, and then neurodevelopmental disability. Our focus of developmental pediatrics should be on this because here near 100% result we can get. Not every case except global development delay. Except global development delay, all other cases near 100, at least 95% result we can get. So why not focus on that? So if you look at the whole, every state you have to have a survey. Whole Kerala we did a survey, one Anganwadi area per panchayat, whole of Kerala less than 3%. 2.8 by 2.5 by TDSC, 2.5 less, don't forget about all this. Less than 3 years, you have 3% development delay. Less than 3 years, 3% development delay. That just calculate how much will be there in Karnataka. That is the role of development pediatrician. I think Karnataka, whoever it is here, sitting here, the authorities, should do the, chapter should do the survey and tell the government that this many number of development delay is there and we need to do something about it. Okay? And habilitation, again, what are the recommendations of NNF as well as international bodies? Before you discharge the child, definitely have a ultrasound examination so that perinatal leukomalacia and all can be picked up not after the child comes with cerebral diplegia. ROP, OAE, screening for development delay, we said, development therapy, passive exercises using amylase and angle, and global development delay, 5%, we need to have genetic metabolic. Now, this is the new concept that has been put into the model, where, of course, Government of India as such have not yet approved, but Government of Kerala has approved. They have already appointed the development therapists under 2 programs in different districts. They are community people, mobile units. One say mobile unit, other government agencies say that they have block the center. What is block? If you have to go to district headquarters for a development delay, how many parents will go? They won't go so far away. Instead of that, you have a multi-purpose person who can identify, who can give some amount of therapy, you can help the child, who can refer, you can take the child to a pediatrician, somebody who is so active. That is our aim. Then you have, of course, prevention of disability going into handicap. Here also we need to have. And there I think we must respect our colleague therapists. This is something I again request you. Don't behave, we are doctors, we are one up above them. No, they are good in their own field. Only problem is they cannot put things together and make a diagnosis. That is where we need to be there. Individually, they are well-trained people and they should be respected. Typically, one new tool I will tell you which is useful, NDST, England tool, which is a good screening tool which will tell you the diagnosis. Okay, and prevalence of NDD India, as per England study, I won't go into all the details to the lack of time. How to define the role of each one in the DEIC. DEIC, I don't know how many of you know that RBSK was designed with Arun Singh. We sitting in Calcutta and he sat there for 1 week and designed it. And development pediatrician should be the team leader or a pediatrician should be the team leader. Development therapist should do the early stimulation therapy for development delay. Development nurse counselor or any nurse should focus on nutrition. Physiotherapy should be, as soon as it is CP diagnosed, should be given to them. And occupation therapy focus on sensory integration. Speech therapist focus on SODA error. Clinical psychologist on LD management, dental specialist on this one. But what is happening now in the DEIC is there is no leader. There is a so-called senior pediatrician as consultant, but he has no power, he has no right. So what happens? If I reach a occupation therapist, whole life I will be there. If the autism child also reach a speech therapist, they will give excellent speech therapy, but autism will not be covered. Okay, so habilitation, okay, I'll skip it because I think time is up. Role of other specialists, I already said it. This is something we need to do. Specialized time, assistive technology. We have not had a talk, have you, or maybe I missed? Have you ever had a talk on assistive technology, your NDP chapters? You are going to have one? Very good, excellent. I think we need to talk about assistive technology because unless, as somebody said in the morning, unless a development pediatrician know about it, we won't use it. That's very important, assistive technology. And as well as AAC, alternative communication. Because why? Because ours is available. Ours is a Government of India supported program. I think some development pediatrician should go for the training. Unless we know, we cannot train somebody. Of course, speech therapists will do it, but I think some of us also should do it. And then of course, guideline for GDD, Madam Juneja has come out with an excellent guideline on management of this one. And we have also one on consensus statement of IAP and AP chapter on management of Down syndrome. We may talk all high fluent genetics, but still our basic problem is still Down syndrome. We should not be forgetting that. And I think I'll stop with this. Okay, Rashtriya Bal Swasthya, how much we have? 238 actively working DICs out of 766. And RBSK need to be empowered, enhanced by having block early intervention centers. So these are the messages I have to give. First 1,000 days, in the middle of the night, if you ask, what is a developing pediatrician? First 1,000 days. We need to focus on the pregnancy period also, not after that. And any good neonatologist will say, transfer the baby inside the mother, not outside. Why? Because that is so important. Thank you, thank you.
Good morning, sir. And that was, I think,